Welcome everybody to the SmartEducation Podcast. Another interesting episode, and today we have amongst us Dr. Toby Hall. Welcome, Toby.
Thank you.
Toby, for the listeners who don't really know you, maybe I can introduce you shortly. Toby is a specialist musculoskeletal physiotherapist. He works at Curtin University in Perth. Toby has, of course, presented at many conferences, worked, peer-reviewed a lot of articles, published many book chapters, and is also a director of Manual Concepts, for which he teaches a range of manual therapy courses around the world. And that is exactly the reason why we have you here today with us at Smart Education. I have to say we're really honored to have you, Toby, with us this week, today and tomorrow, and even during the weekend. Today was the first of a 2-day course on integrated manual therapy for the lumbar spine. And the course covers actually evidence-based functional evaluation of pain disorders of the lumbar spine and thereby classification for appropriate management. That is the reason why I invited you here today for a podcast, to go into some specific elements of the course of the lumbar spine that we're doing today and tomorrow, but also about headache. Let me start with the low back or the lower spine. Last summer, the Lancet published a series of 3 papers written by a large international group of experts who came together to raise awareness of the extent of the problem of low back pain and the evidence for recommended treatments. The authors were actually very critical about the widespread use of inappropriate tests and unnecessary, ineffective and harmful treatments. So I'm really curious about your opinion, more particularly on the role and the place of manual therapy in the treatment of low back pain, besides, of course, education and exercise.
Thank you, Stein. And I think this is a very important series of papers. I really encourage physiotherapists to read these papers if they can. It's written by some of the world's leading experts on management of back pain, and it points to a new direction to help to try to change some of the disability associated with back pain. We know that in recent years there's been an increase in disability, and in fact low back pain is now the most disabling condition with neck pain in the world, and in fact it's getting a worse and worse situation. So it seems that what we've been doing in the past perhaps is the wrong approach to managing this complex problem, and we need a new approach. And so this paper was a call to arms, really, to try to encourage people to have a different approach to the management of this problem. Now, I know in the past we used to use manual therapy as a way of treating all patients with back pain. That's what I was taught in the 1980s when I first graduated, that we could apply Maitland mobilization techniques on all patients, because we didn't really know what else to do with those patients at the time. And we tried, and it worked for some people, but it doesn't work for everyone. Now, with new research and new evidence, we have a much better understanding about how we can manage this disorder. And we know that back pain is really a part of life. It's a common thing. We don't need to worry about it. It usually gets better if you don't do anything. But if you worry about it, if you get the wrong idea about back pain, it can become persistent. And some people do have persistent pain. So for general low back pain, we need to understand that we don't really need manual therapy for many patients. And if we encourage them to keep active, to return to work and exercise, they're going to have a good outcome. But the guidelines that are published around the world show that if we don't have a good outcome, then perhaps we should introduce manual therapy as a secondary approach for those patients. And then the evidence suggests that it can be helpful if we combine it with other treatment approaches. So as a standalone treatment by itself, I don't think it's something we want to recommend for all people who have back pain. But for those people who don't progress as we expect, then it can be a useful adjunct. And it's a component of a multimodal treatment approach, incorporating exercise, incorporating education and changing beliefs in a biopsychosocial treatment approach.
So actually it also comes down to good classification of low back pain patients. and then given them the appropriate treatment.
Yeah, I agree, and that's the core component of the course that I teach today, is really to try to get the message across that back pain is a complex problem. We can't treat everybody in the same way as we used to do, and that we have to assess each individual patient and treat them according to what we find. And some of them have different problems, each of them requiring a different type of treatment. And if we can classify them, incorporating various different elements of classification, I think we have a better chance to help those people and prevent them from developing persistent pain.
Yeah. I hear you mention today during the course also that actually you said, I quote, exercise should be a core component of treatment. Yeah. Can I add to that exercise should also be a core component of just regular healthy living?
Yes, I think that's very important. But I don't think people understand the benefits of exercise. They don't understand the benefits of treating many different health disorders, but they also don't understand how exercise can prevent disease from occurring, and how a healthy life incorporating exercise is going to help you live a much more healthy lifestyle and prevent disease from occurring in the first place.
Do you think that physios are doing a good job to getting that message across to the public?
I think it's been...
And maybe also to the GPs.
It's a good question. I think we are seeing some new directions from physiotherapists, some very important papers coming out showing that we should change directions. And some of this information is getting into the mainstream press. If you look in various newspapers around the world, there are some good articles that are written by physiotherapists. Mary O'Keefe in Ireland, Kieran O'Sullivan in Ireland, Peter O'Sullivan from Australia, that they're putting out some important messages to people to try to get this message across. But unfortunately, at the same time, there is also some poor information from other directions that can be confusing for people because they get a mixed message and they don't know which is the correct message to listen to. So we need a more concerted effort and a strong voice.
Well, the first message that they get if people are having some complaints, musculoskeletal pains, they go to the GP, and what does he say or she?
Well, you would
take this pill, have some rest, and if it doesn't get better, maybe we'll send you to a physio.
That's right. It's
tough message. to compete to that as a physio.
Yeah. Unfortunately, physiotherapists are not so well listened to by the general public. And I think we don't have such a strong voice, but I think it's beginning to change. I do see that in the various messages that are going out to the public, that I think we're on the
right path,
the crest of a new wave, hopefully.
Okay. Also, something else. Since we're talking about education, I interrupted you during the course because you were explaining about imaging and results that come from imaging that maybe are mostly get people worse. MRI, right. Doing an MRI gets people with back pain worse. And you said that it's important that physios should educate the patients about those results. And I asked you a question: shouldn't we firstly educate the GPs about imaging and the message they are getting across? Shouldn't we be confronting them with these studies, with these articles, and try to explain to them that they should give positive messages?
Yeah, I think that's an important point, that we need to educate all people who are stakeholders in the management of patients with back pain. And physiotherapists sometimes are a little bit behind on the current research evidence that shows that imaging is not so helpful. But I think also some of our medical colleagues are not up to date with some of the information. If you look at how far behind medical practitioners are in terms of their knowledge about evidence-based practice, it's a little bit scary about how many years it takes for them for this new information that's not all that new to filter through to people. So I would encourage people to read the literature, particularly these new papers in the Lancet, and there's a whole series of other papers that are giving some guidance about how we should use imaging. Imaging is something that we need to consider when we think there may be a serious pathology, but for general practice, it's not important. In fact, it could have a negative effect because people become fearful about what they see on the imaging in terms of degeneration or disc prolapse, and this becomes their main focus. So the way that we describe what the imaging shows is important, and there's some important work from Ben Darlow and some of his colleagues and some of Peter O'Sullivan's colleagues who have looked into this important area to try to inform people about what they see on this imaging. So I would encourage the doctors for sure to be aware of this new information.
I remember Christian Barton mentioning once, one of your fellow Australians clinicians, that it takes about 17 years to
it's a crazy amount of time, isn't it?
Yeah, evidence into practice. Yeah.
That's right.
Yeah.
Yeah, so I think now with new technologies, we should be a little bit quicker at getting that information through.
Through social media, through...
Yes, and we there are methods now, like Christian Barton is producing some great work with infographics where we can explain about some of the new information about how we should manage patients. Now, it would be nice that our medical colleagues were reading this new information, but, it's not really my place to tell medical doctors what they should be doing. There should be some education within the profession about how they should manage their patients and some guidance from them. So while I support educating people, I think we have to be careful about criticizing our colleagues when, in fact, they're trying to do their best, but perhaps in a difficult situation.
I understand completely. Let's move on to another subject, another topic about headache, because later this week you will give a course on evidence-based manual therapy examination and treatment techniques for specific headache disorders, including cervicogenic headache. What are the main insights and take-home messages, together with some practical skills you want to share with the participants and with our listeners?
Yeah, well, I think headache is in many ways similar to back pain. There are many different types of headache. We know that headache is a disease as well as a symptom. So, if you have headache secondary to a tumor in your brain, then clearly we have to be careful about how we treat that person. If you have headache because of a disease process like migraine, then it's a different situation completely. So if you look at the International Headache Society, they have a classification system with more than 300 different types of headache. And not all of them are suitable for physiotherapy, never mind manual therapy or exercise. So we first of all have to classify the headache disorder.
Just like low back pain.
Like low back pain, and know that they do have a cervical spine problem that would respond to some treatments. And there's some good evidence that perhaps 4.1% of the global population suffer from cervicogenic headache. Perhaps 20% of all headaches where people seek treatment in primary care could be cervicogenic in origin. So that means that we can help quite a proportion. We also know there's some evidence that we can help people with tension type headache. And that's the most prevalent condition of all headaches. If you combine tension headache with cervicogenic headache, we're talking about more than 45% of the global population who suffer from those two types of headaches. But there are many other types of headache where we can't treat. So we have to be clear to differentiate between them and then use appropriate treatments. So we have some classifications based on subjective information and also based on physical examination criteria that we can use to differentiate the different types of headache. And then we have a chance to be able to help those people.
Yeah. Today, there was somebody who approached me who did the headache course last year. And she also follows the literature, and also she's active on social media. And she said, I don't understand all this fuss about manual therapy that it doesn't work. I went to Toby's course last year, and it works. I see my headache patients. I loved seeing a headache patient coming in because now I have some extra skills on how to approach those patients, and use a classification. So
That's great. It's good to hear. It's really nice to hear feedback from people who've been on the course and actually that's how it's worked.
Why you do it as well.
It's really rewarding to hear people have used and I get lots of feedback from people who write to me by email and have very positive feedback. I know you don't tend to hear the negative feedback from people, but it's nice to get positive feedback and success stories from people who've treated patients and had some very good
results with that. Maybe a final question, maybe just one more. I already asked a little bit about it, but maybe I'll ask it again. What challenges holds the future for yourself in the first place, and maybe go a little bit broader for physiotherapists around the world? Are there specific areas of interest, for example, in research, that you think we should look out for?
Yeah, that's a good question. I think the challenge is to bring the evidence into practice, so that we're trying to incorporate better ways to treat patients that are based on evidence, and that's always a challenge. I think manual therapy is at a crossroads. We have some important information based on the evidence to show that perhaps manual therapy is not as effective as we thought it was in the past. It still has a place, I think, if we apply it but we need to know a lot more about when we should use it, how we should use it, and how effective it might be for different conditions. So we need to do more research about its effectiveness, I think, and also it's what it actually does in patients. We don't even have a clear understanding about some of the mechanisms involved in manual therapy. So I'm interested in learning more about classifying people with pain and knowing when manual therapy may be effective and what kind of subgroup might be effective for that kind of treatment.
Yeah, I remember you mentioning an article that went into that a little bit. It was about reconceptualizing manual therapy skills and use it as an assessment tool.
That's what we wrote a paper with some of my colleagues about how we should use manual therapy moving forwards. And it's about reconceptualizing the use of manual therapy. And it was a series of cases and little vignettes about different types of problems. And one of them was a patient who had an acute back pain disorder involved with an infection in the lumbar spine, and how we might use palpation together with some other clinical reasoning information and skills that can help us to identify that this possible site of infection, which could then be investigated further with other tests. So I think manual therapy is both an assessment skill, and it can also be an intervention, but it's not suitable for everyone.
Okay, clear enough. Let's end with that. It's a positive message. The future is still bright for manual therapy.
I think so.
And I wish also you all the best in the future. Hope to see you again. Why not every year?
I hope so.
There's still a lot of interest. We get a lot of people who want to register for your course each year. So we'll be inviting you next year if you're up to that. And we also invite all of our listeners to join one of the courses of Toby. I can say myself that it's always a pleasure to hear you speak with all your knowledge about those whether it's about low back or headache or maybe some other cross-cervical.
It's a pleasure to be here, especially in a place like Belgium, a wonderful place. And Leuven's a beautiful city, and I really enjoy coming here, not just for the beer and the food, but also we have a very nice group of people who are very interested. So thanks very much.
Thank you, Toby. Thank you for this interview.